welcome to my third part of fetal therapy. Today we'll be discussing about the surgical management. My earlier two parts which were there on fetal therapy involved the medical management of various conditions in the fetus and how we go about it, what are the conditions, how do we and what do we give to the mother so that the baby is alright in utero. You can go through these videos on my Facebook page. It's available there. It's there on my YouTube channel as well. Those of the students who've just recently joined me, I have posted it to the group as well, and I've given them separately personally as well. But still, the ones who've not seen it, it's just advisable that you just go through it quickly. And it's not lengthy videos like I always say. I make short videos so that it's easy for you to finish one video quickly and efficiently and remember more. It's easy for you to see in between your work, while traveling, while in between your work, your chores, going from one place to the other. It becomes easy for my students, and I get good feedback from you, and that makes me also feel that if I make smaller videos, it'll be easy for you and it'll be easy for me, both of us, for you to comprehend, for me to make simple. So anyways, today I'm going to talk about the surgical management of the baby in utero. It's advisable for you to just go through page number 318. There is a table 16.1 which is given. See, when I talk about fetal surgery inside utero, multiple questions crop up in your mind. What about the draining liquor? What about the risk of preterm birth? What about the risks to the mother? What about the risks to the baby? Alright, despite all these risks, if I'm talking about an open surgery, what are the conditions? So let me just take you through a brief tour about the surgical management of the baby. It's divided, for simplicity's sake, into open surgical management, fetoscopic surgical management. Lots of work is done on this because it's anything which is minimally invasive is always going to show better results. So, and then percutaneous treatment, and then comes the exit procedures. I'll talk about each one of them. I'll take a separate class, but the most risky procedure of all is the first class that I'm going to take today, and that is open surgical procedure. Now, when you see through your Williams, basically my entire class is made up of from the Williams notes, and I have also consulted a few other books which were there with me and which are from foreign authors, because usually most of the work is done outside India. It's done basically in America. Some of it is done in Australia as well. So I've read those authors' notes as well and combined them into this class so that it's easy for you to comprehend. Like I said again in my previous class, people do not want to hear, especially the TNB examiners, from you people, your postgraduates, very minute details of any surgery. Nobody is going to ask you to describe the surgery of myelomeningocele inside a uterus, inside a baby in utero, and the minute details of that. People would just want to know whether you have a rough idea as to what you are talking about, what this chapter is all about. What do you mean by surgical management of the baby inside the uterus? So, when they talk about open surgery, open fetal surgery, there are certain prerequisites that you need to know, or there are certain prerequisites that you would want to know and talk about to the couple when you're talking about a surgery to be done on the fetus inside the uterus, right? So those basic things are given in page number 318 and that will tell you what all things you need to know before you talk to the couple about a surgical procedure to be done on their fetus, right? And then once you've read this table, you would know that these are the things. See, I'll just roughly tell you what it is all about. That table tells you that first of all, the diagnosis of that particular defect in the baby should be very absolutely certain. One, there should not be multiple congenital defects. It should be only one, and that too, the surgery should be feasible. The team should be available. It includes a multidisciplinary team, obviously, and that to everything pediatric anesthesiologist, pediatric surgeon, fetomedicine specialist. So that team, the multidisciplinary and super specialist team, should be available in your hospital. Extensive maternal counseling should be done, telling them, giving them in statistical figures the amount of risk, what risks are involved, how much is the potential risk, and everything should be written and documented, and so on and so forth. This particular table will go for all the procedures. So even if you don't remember anything about that particular procedure, you don't remember fetoscopy mein kya kya aata tha, what was there inside, you will at least remember that table, and you'll have something to write in your answer. Alright, so that table is very important because that will go on all these surgical management if anything is asked. Now, when I talk about open surgical procedure, like I said, the danger of the open surgical procedure is the most risky surgery amongst all of them is the open surgery. So, what exactly will be the treatment plan of an open surgery? I'll tell you that. Of course, there will be extensive pre-op counseling, multidisciplinary care. You would have to tell them that the mother will be under GA. Okay, so obviously the mother will be intubated, endotracheal intubation. The uterus is going to be quiescent by tocolytics. That will be told. Warm NSCL will be transfused because obviously when you're operating upon the baby, there will be loss of the liquor, and sudden loss of liquor leads to placental detachment. So that thing has to be told to them that warm NS will be flowing inside to keep the compartment safe. The cushioning effect will be maintained intra. Tocolytics will be given intra. Intra-op ultrasound facility will also be available because the moment you'll be giving hysterectomy, wherever you'll be giving, placental edge should be saved. Placental edge should be saved when you're giving the. Okay, once you've given the incision, the hysterectomy incision, there'll be stapling device available. Okay, I don't know in which centers do you really have it, but stapling device is available to seal the edges of the uterus so there is not much bleeding, because any bleeding from the maternal side does affect the baby, and we are trying to do this operation to save the baby, isn't it? So we don't want to end up losing the baby just because we operated on it, right? And like I said, the fetus is going to be gently manipulated, taken out. IV access has to be maintained in the baby as well. You're operating on the baby, so you have to give anesthesia to the baby as well. So IV access is maintained through that. Pulse ox is taken. Tocolysis is usually maintained by Mexal for 24 hours, by indomethacin for 48 hours, and nifedipine is continued till delivery. Mention that when you're talking about open surgery and you're talking about the management. The intra-op, of course, antibiotics are given. Steroid cover is already given pre-op, and you will now proceed for the open surgery. The conditions that we'll be talking about in open surgery will be two basically: a myelomeningocele defect and a sacrococcygeal teratoma. We'll be talking about those two defects basically, and the risk of an open fetal surgery will be pulmonary edema is there in 28%. There is the placental abruption is there in 9% of the cases. The preterm pre-rupture of membrane is available in 52%. Available in the sense it does happen. There is a risk of 52% cases going through preterm labor is a very big risk, so 33% chances there. Uterine rupture, you have 14%. Uterine dehiscence can also take place, that is 14% again. So these were the high risk factors. You have to counsel them accordingly. In open surgery, there's a very big risk of prom and preterm labor. I'll repeat it again if you want to. Prom is there in 52%, preterm labor in 13%. There is a chance of uterine dehiscence and uterine rupture almost equivalent, that is 14% each. There is a chance of pulmonary edema because so much of fluid is being transfused just to maintain the compartment. So 28% chance is there, 28 I said, 28% chance, and then there is 9% chance of even abruption, sudden abruption. The placenta gets detached. I'll describe the myelomeningocele in a nutshell. Like I said, they'll not be asking you the steps. They'll be asking you surgical management of the fetus, utero. So you have a lot to write. Myelomeningocele will just be an add-on feature to write down. Okay, a surgery on myelomeningocele in the fetus and utero is one of the conditions you would want to go for an open surgery, because a defect, how will you close the defect through a fetoscopic surgery? How will you close the defect through a laser? Because this is herniating membrane outside. It's a part of brain literally coming out of the baby. So you have to be very gentle and you'll have to be very explicit in this. You cannot take a smaller or shorter or a scopic course in this. So myelomeningocele, first of all, you have to do a laparotomy, okay, on the mother, a hysterectomy again on the mother. Then skin around the defect is incised, and then neural placode sharply dissected from the arachnoid membrane. I am reading it out so that it's easy for you and I don't miss out on anything. you've got to write it down exactly in this order. You can write down through flow charts. So after laparotomy, hysterotomy, skin incision defect, skin around the defect that's slowly incised, and the neural placode is sharply dissected. This is the neural placode I'm talking about. Dissected away from the arachnoid membrane, the closest. The dural membrane is reflected to the midline to cover the neural placode, and it's reapproximated using the suture. Sometimes you might require a patch if the defect is big. So the dural membrane is reflected to the midline to cover the neural placode, alright, and then it is reapproximated using the suture. Finally, the fetal skin is sutured, okay, then the uterus is sutured, and then comes the maternal skin that is also sutured. Now, why do we require this myelomeningocele surgery in the baby? Why do we not just leave it over there? So the reason is basically multi-centric trials have been done, and the mom's trial was done, and that came out with the answer that those baby who've been through surgery, they had 2 times better motor skills as compared to the babies who did not go inside the uterus. The ones who had outside the uterus, the ones which had this inside the uterus surgery, they had a 2-fold higher chance of development of motor skills. They were able to walk at 30 months of age. Alright, the ones who did not have, they walked maybe late, maybe did not walk at all. Then ventriculoperitoneal shunt, that is usually required. Ventriculoperitoneal shunt, that is usually required at the age of 1 year. Even in those cases, sometimes which are operated inside, that is negligible, almost marginally reduced in the people, in the kids who had this surgery inside the uterus. The fetals who got inside the uterus, almost half of them did not require it at the age of 1 year. Okay, just half of them. Usually, we're comparing it with the ones who had it, with the ones who did not have it in utero. The difference is this. And it's not that I'm saying that it's exceptionally successful and the fetus who've had the surgery inside the uterus, they are doing exceptionally well. They also have paralysis of the lower limbs. They also are not able to walk at all at 30 months of age. Of course, we've got no explanation to tell them that despite the surgery, this is what is happening to them. But this is the idea behind extensive counseling. And now let's talk about the second surgery that I spoke about, that is sacrococcygeal teratoma. The tumor is there, okay, around the sacrum. So again, laparotomy is done, uterus, the hysterotomy is done, and the tumor, you reach the tumor and slowly dissect it and resect it out, and again close the defect, close the uterus, close the laparotomy wound. Basically, this is what you've got to write down in your answer sheet. But you write it down through flow charts, like I just told you. You'll be, giving something to the examiner to understand and tell him that we know the answer. Only for sacrococcygeal teratoma type 1. Okay, now there are many types of teratomas as well, but this surgery is basically scheduled for type 1 type of teratoma, in which the defect is completely external. Now remember this. Sacrococcygeal teratoma, there is type 1, 2, 3. Okay, type 1 is the defect is completely outside. That's the only way in which you can help the baby. Otherwise, once it's also inside, how will you be able to do justice, taking so much risk to the mother? That's still, just excising part of it. Okay, so this was all about open surgery today, and just go through that the table that I told you. If you've got nothing to write, even if you don't remember myelomeningocele step by step or sacrococcygeal teratoma, what I've told you, that thing will be good for you to write down. And if you even mention these words, myelomeningocele and sacrococcygeal teratoma is done through open fetal surgery, I think you'll be getting all right marks. If I am the examiner, I will give you marks for this, because this is maximum that is expected out of you. And as far as question is concerned, I don't think question will be open fetal surgery, Cooper write a short note. Even if it does come, this much is sufficient for you to write. My next class will be on fetoscopic surgery, so watch out for that.